Hi, this is Dr. Butts, and this video reviews cardiac output. This is an overview of the factors that affect cardiac output. And so we will go through stroke volume and the factors that determine stroke volume, and we'll look at heart rate. First, we'll start with defining cardiac output. So cardiac output is the amount of blood pumped by the heart in 1 minute. And the average cardiac output is 4 to 6 liters per minute. And this volume varies by body size and blood volume. Cardiac output is determined by the stroke volume, the amount of blood pumped with each beat, times the heart rate, the number of beats per minute. To maintain a normal cardiac output, we adjust our stroke volume or heart rate as needed. For example, if an individual's stroke volume decreases, then to compensate and maintain a normal cardiac output, that heart rate will increase. Sometimes, like with exercise, we may need to increase our cardiac output. And we can do this by increasing both our stroke volume and our heart rate. So let's look at some mechanisms that determine cardiac output. We'll start with stroke volume. Stroke volume is determined by preload, afterload, and contractility. Preload is determined by our end systolic volume and our venous return. Preload is the pressure generated at the end of diastole. So it is our end diastolic volume, the amount of volume we filled at the end of that diastolic part of the cardiac cycle. Preload is determined by end systolic volume, that amount of blood in the left ventricle after systole, so how much is left over after we've pumped. And preload is determined by venous return. Venous return is the flow of blood from the periphery back into the heart. Venous return has the largest effect on preload. Venous return is driven by increased blood volume, and so a higher blood volume will lead to an increased venous return. Things that can increase blood volume can include things like aldosterone from the renin-angiotensin-aldosterone system and ADH, antidiuretic hormone. Another factor that affects venous return is vasodilation, and this will decrease venous return. Sometimes we want to decrease the work of the heart, and so we can use medications like nitroglycerin or nitroprusside to dilate those veins and decrease venous return, thereby decreasing preload. In addition to preload, stroke volume is also affected by afterload. Afterload is determined by aortic pressure and total peripheral resistance. Afterload is the resistance to ejection during systole. So it's how hard that left ventricle has to pump to get blood out of the ventricle and into the peripheral arterial system. Afterload is determined by aortic pressure, so the amount of pressure in the aorta. Something that would increase aortic pressure would be something like aortic stenosis, where that aortic valve is stenotic, or if the aorta itself is stiff. Afterload is also increased with total peripheral resistance. So something like vasoconstriction, where you have narrowed the lumen of the blood vessels increases our blood pressure, and so that is going to increase our afterload. Vasoconstriction is driven by things like the sympathetic nervous system, angiotensin II, which comes from the renin-angiotensin-aldosterone system, and the vasopressive function of ADH, so it's also called vasopressin. Total peripheral resistance is also affected by blood viscosity. So something like polycythemia would increase blood viscosity. Because afterload is that resistance to ejection during systole, during that time the heart is pumping, a higher afterload would decrease that stroke volume or increase the work of the heart in order to get that blood out of the heart. And so afterload can decrease blood volume. And so something like hypertension would cause a chronically high afterload. So stroke volume is determined by preload, afterload, and now we'll look at contractility. Contractility is determined by end diastolic volume, sympathetic stimulation, and myocardial oxygen supply. So contractility is the strength of contraction during systole, and that's of that left ventricle. So how hard, how strong is that force or that contraction of the left ventricle? If you want to increase stroke volume, you're going to increase contractility. And so contractility is increased when you have an increased preload or increased end diastolic volume. And that is that Frank-Starling law, where the more you fill the ventricle, the more it can snap back and contract harder. So like the further you pull out a rubber band, the further it can snap back. Contractility is also increased with sympathetic nervous system stimulation. And so that can make the heart pump harder. In times of myocardial ischemia, this can decrease contractility. So if the heart is not getting enough oxygen, you're going to decrease contractility. And so you can see this with coronary artery disease or heart failure, where that chronic stretching of that ventricle compresses those walls and causes repeated bouts of ischemia. So we've looked at stroke volume, and now let's look at heart rate. And heart rate is solely determined by the autonomic nervous system. And so with heart rate, you can only increase it or decrease it. And so our catecholamines, epinephrine and norepinephrine, are going to increase our heart rate, make our heart beat faster. And if we want to slow our heart rate, if we want to decrease that heart rate, the vagus nerve will release acetylcholine to decrease that heart rate. So let's summarize the mechanisms that drive our cardiac output. So the sympathetic nervous system, through our catecholamines, epinephrine and norepinephrine, can increase heart rate and increase myocardial contractility. Increasing that contractility increases stroke volume. So the sympathetic nervous system can increase cardiac output through increasing heart rate and increasing contractility. The sympathetic nervous system can also increase peripheral vascular resistance through vasoconstriction. And so this will increase our afterload, or how hard that ventricle has to pump to get that blood out into the periphery. Cardiac output can also be affected by the renin-angiotensin-aldosterone system, or RAS. Activation of RAS leads to the production of angiotensin II. Angiotensin II is a vasoconstrictor, and so that is going to increase our afterload. RAS activation also leads to the production of aldosterone. Aldosterone goes to the kidneys where it saves sodium. Water follows, and thereby it increases our blood volume. And so aldosterone can increase that venous return or increase that preload. Antidiuretic hormone, also known as vasopressin, can increase our blood volume. So this has an antidiuretic effect. And so it goes to the kidneys and holds onto water. Again, that increases our blood volume and can increase our preload. And ADH also has a vasopressive effect. And so this vasoconstriction will increase our afterload. And finally, ischemia. So if we have a decreased myocardial oxygen supply, this can cause a decrease in contractility, and so that could decrease our stroke volume. And that is our overview of mechanisms in cardiac output.